Good morning, everyone. This is Karina Hill, and on behalf of the Florida Alcohol and Drug Abuse Association, we want to welcome you to today's webinar entitled Complex PTSD, a debated diagnosis and how it impacts individuals with substance use disorders. And our presenter today is Trish Caldwell. This webinar is being made available through a collaboration of the Florida Department of Children and Families Office of Substance Abuse and Mental Health and the Florida Alcohol and Drug Abuse Association. We want to just let you know that as an attendee, you're in listen-only mode and will only be able to view your name. If you have questions, we ask that you please send them to the presenter and myself. If you look on your drop-down menu, you can select presenter and host, or you can say all panelists. And if you would please put your questions and comments in the chat panel rather than the Q&A panel, we would appreciate it. The button to open the panel is usually located on the upper right side of your monitor. Please again use the chat panel instead of the Q&A panel to send any questions as you think of them, and the presenter will address them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and those options were posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in using the telephone I will call in option. One thing is you must be connected to the audio of this presentation and also view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 30 business days. We do try to have it posted sooner, but it can take up to 30 business days. One helpful hint is the archive video displays what looks like to be an error message, but it's only a delay buffer, so you can ignore it, hit play, and enjoy. To access the recording in PowerPoint, you would go to our website, www.fada.org, to our Resource Center Training Library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. And to help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credit for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on the FADA website, and we do appreciate your feedback. You will first need to register or sign into your account to complete the evaluation. Information that you provide FADA as part of registering does remain confidential. Statement of credits will be posted within 30 business days after the evaluation closes. So once you complete the evaluation, it does not post immediately. Again, it's 30 days after the evaluation closes, which will be Tuesday, October the 13th at midnight. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Again, it does close on Tuesday, October the 13th. 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, please be sure to include your Florida license number for reporting to CE Broker when you register with our site. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. One thing I would like to mention is that WebEx does monitor the arrival and departure of all attendees, and it provides a report to us upon completion of the event. So we are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. We are not permitted to provide partial credit. And with that being said, I'd like to introduce our presenter today, Trish Caldwell. She's a Family Services Corporate Director for Recovery Centers of America, an adjunct professor at Jefferson University, and a trauma trainer for Lakeside Global Institute. Trish is a licensed clinician, marriage and family therapist, and is certified in both co-occurring disorders and substance use. Trish has been a therapist for over 25 years and has worked extensively with families, young adults, and adolescents with co-occurring behavioral health and substance use disorders in various settings, including outpatient, residential, schools, and community agencies. She is trained in DBT and is a certified trauma professional. And Trish, if you are ready, we can go ahead and get started with your presentation.
Wonderful. Thank you so much. All right. Well, welcome, everybody. Good morning. I want to just start with kind of a little bit of an overview. We'll get to the objectives in a second. So again, as you have heard, the majority of my career has been spent in the behavioral health and substance use kind of genre. And so what today's topic is going to be, I'm going to lean a little heavier in the exploration of complex PTSD, how trauma and early childhood trauma can impact an individual, and then we'll interweave a little bit of its relationship with substance use disorders. So I want to just give that as that head. So again, the objectives today is to help you to differentiate between PTSD and complex PTSD. So we'll talk a little bit about that. For those of you that are less familiar, we are going to talk a little bit about the ACE studies, the Adverse Childhood Experiences study that was done by Vince Felitti and Kaiser Permanente, and kind of what came out of that in regards to risks and vulnerabilities and how we understand that today. We'll look at examining complex trauma from a developmental and strength-based lens. So breaking that down, we're going to look at it in regards to how do the experiences of trauma impact the brain throughout the course of an individual's life. So depending on when the experiences have occurred, it's going to change the way that the individual responds. So we'll talk a little bit about that, and then utilizing a strength-based lens, I'm going to continue to say this message. The brain is an incredibly plastic part of who we are, meaning it is always open to changes. And so while I discuss some of the implications that trauma have on the development of the brain, what I want the continued message to be is that through shared connections, through appropriate treatments, through community organizations and opportunities for growth, people can and do recover every single day, not just from their traumatic histories, but also from substance use. So the strength-based lens, I'm hoping that that's not going to be, that you won't hear that in regards to like a slide. I'm hoping that what you'll hear is through the extensiveness of today's training, that you're going to hear that strength-based lens throughout the whole thing. That while we understand this, to me, knowledge is power. To me, the more that we understand and the more we're able to share with those that we're working with. So if you are working in child protective services, if you are working in the foster care system, if you are working in community agencies, if you're working with children or adults, that when we understand the why, it not only gives us an opportunity to do things differently with them and provide them some skills that can appropriately address some of their needs, the why also helps them to understand, why do you do these things? Because for the overwhelming majority of those that I work with and have worked with, the shame and the stigma associated with the behaviors oftentimes becomes one of their biggest barriers. When they understand that this makes sense in the context of how your brain developed, in the context of your situation, in the context of what you were trying to do in the moment, your behaviors make sense. It allows people to not feel like there's something inherently wrong with them and that there's potential for change. So again, I'm hoping that as we kind of go through this, that the overarching theme is not going to be a slide where I talk about strength-based lens. It's that, to me, it is a strength-based lens. When people understand themselves, when we understand their behaviors and we become responsive instead of reactive, that is strength-based. And then we're going to talk a little bit about, so what are the treatment options? The regulation interventions to help individuals acquire those skills necessary, because when we talk about complex trauma, we are talking about those that have been impacted at a younger age oftentimes. And so it becomes important for us to understand, if we understand how the brain operates from the bottom up, from the inside out, that we provide them regulation skills to be able to heal that internal part of their brain so that they can allow themselves to get to the top part, which allows for their healing to take place. So that's what we're going to be going over. As you had already heard, if you have any questions, please feel free to send them into the chat box. I think it's more helpful. Honestly, what normally I do is ask or answer the questions as we go through this. We will have a break roughly about 11 o'clock. We will end about 11:50. So keep that in mind as you're trying to plan for your day and figuring out when to take your break. But I have found that it is more helpful and more beneficial when I answer your questions as we go through. So please feel free to send them into the chat box as they pop up for you. So I think it becomes important for us to define what trauma actually is. That when we start to look at this, that stress can be measured across two dimensions. It can be measured in regards to its frequency and its degree. Here's why it's important for us to kind of keep in mind, the terms. So I am a person that believes in the importance of our language, right? So changing our shared language in regards to substance use disorder rather than, an addict, changing our language in regards to somebody that's been impacted by trauma rather than a traumatized person. I do think that there's meaning behind that, and I do think that there's relevancy. I spent a very large part of my career working in an underserved community where there was a lot of young men that had been living in an environment where there was violence, where there was experiences where they might have been shot, where they were experiencing racism, where they were experiencing underserved opportunities in regards to education and jobs, where they had community violence. And what they struggled to identify was, I don't have trauma. So I think it becomes important as we have this conversation about the frequency of stress, because what they could identify, and again, whether somebody identifies themselves having PTSD, complex trauma, traumatic experiences, or whether they're able to just identify that there's been stressors in their lives that impact their physiology, what I have found is for some, that was a more acceptable piece. And so I do think that it's beneficial for individuals to understand what stress is and how it impacts the body. So when we're looking at stress being measured across two dimensions, the frequency and the degree, it becomes important kind of recognizing that. That when we talk about the frequency, acute, which is shorter term, versus chronic, which is more in line with what the individuals that I was working with, versus generational, meaning that the stress is coming from multi-generations, which we also see. When we talk about the frequency of stress, you might see this in first responders as well, that for many first responders, and for those of you that maybe are working in regards to first responders, what you will also identify is that the frequency of their stress is oftentimes chronic in nature. And so as we're looking at this idea, is obviously that the more somebody has, the greater the impact it's going to have on an individual. When we start talking about the degree of stress, we're looking at positive, tolerable, and toxic. When we talk about positive stress, we all kind of have some familiarity with that. It refers to like moderate or short-lived stress responses. So a brief increase in your heart rate or mild changes in the body's stress hormone levels. And again, we're going to talk a little bit more about this as we go through it. It's oftentimes more mild. it's oftentimes more predictable. And I just did a conference yesterday on stress, and we talked about that, the predictability versus unpredictability, and how that changes our coping mechanisms, how it changes our ability to become more vulnerable versus resilient. So, obviously predictable stress is more tolerable because you can prepare for it, because you can put things in place. But oftentimes what happens is that unpredictable stress is where there's an increase in the vulnerability. So when we're looking at, again, in a positive sense of stress, you're looking at that it can occur against the backdrop of generally safe, warm, and positive relationships. So somebody has something that happens in their lives, but overall, the overarching environment for them is conducive to managing that level of stress. So I will say, for an example, just as this morning, as we are all trying to figure out this new world, I have a 14-year-old that's in high school who something changed on her online because she's now doing virtual school, which is changing into, a hybrid method. That this morning for her was significant stress. But the environment is conducive enough that she can mitigate it and allow herself to then recalibrate. When we start looking down the degrees and we start looking at tolerable, it refers to stress responses that have the potential to negatively affect the architecture of the brain, but generally occur over a limited time periods that allow the brain to recover and therefore reverse potentially harm effects. It oftentimes is more moderate in terms of occurrence and severity. It primarily focuses in the context of an ongoing relationship with supportive adults, right? So again, it's tolerable. People get used to it, but in the absence, and so this becomes an important piece because when we get to complex trauma, this is going to be a significant differentiator. In the absence of supportive relationships, tolerable stress can become toxic. So let me say that one more time. So what one person might be able to tolerate for tolerable stress, in the absence of supportive relationships, in the absence of connectivity, tolerable stress can turn into toxic stress. So if we were to use that same simple example, right, of my daughter, so again, we're taking something relatively simple, where she's experiencing high levels of stress for herself in the moment. If she does not have the ability to have an environment that is allowing for her to have some sense of safety, then that stress will stay within her if it continues day after day. And so this is a really important time for us to have these conversations, because with so many of the stay-at-home orders, with so many children working literally school from home, what might have been tolerable stress. So all children, and so as we have these conversations within our country about, do kids go back to school, do they not go back to school? And while I'm not getting in the middle of that debate, what I think we need to continue to be conscious of is the impact. So tolerable stress, again, going from in-person learning to online learning would be tolerable stress. Having changes on your Wi-Fi, having changes for, consistency on what am I going to do on my day-to-day. Something happening where a parent might have to call out of work for a day is tolerable stress. If the environment is not conducive to supportive relationships, generationally, there might be opportunities where families did not learn the nurturing aspect of how to support one another, that there might be other implications in regards to, unemployment and finances and food, that their tolerable stress will turn into toxic stress. When we start talking about toxic stress, it refers to strong, frequent, or prolonged activation of the body's stress management system. And again, we're going to get into this pretty significantly as we go through this. Toxic stress tends to be unpredictable and severe. It's often experienced without having access to support from caring adults or at the hands of an adult who's supposed to be caring. Again, a very key point right there. So while some environments are not, we talk about the importance of a primary person, and again, I just watched a movie when I was part of this conference on trauma, there was a movie on resiliency, right? The biology of stress and the importance of resiliency. And it talked about the importance of in supportive adult. So while there are these extenuating circumstances that might prevent the family from being a primary role in providing some safety initially, having an adult becomes significant in the way a child processes that stress. So when we go back to looking at today's pandemic and more children being at home, for some children whose family members might be also struggling and also trying to figure out how to get done the day-to-day, that child has likely lost the adult, that one person, who might have been a teacher, who might have been a guidance counselor, who might have been a lunch aide, who might have been the custodian. They lost that one person because they are now in the home. So that toxic stress, which we'll talk a little bit, that's where we're going to talk mostly in regards to the complex trauma, can adversely affect development in a number of ways, including altering the brain architecture or recalibrating an individual's stress response system. That's where we're going to be talking when we start talking about complex PTSD. When we're talking about trauma, again, defined in regards to chronic toxic stress, that these cases are illustrative and not exhaustive, meaning that there's always things that are going to continue to impact. 6 months ago, we wouldn't have known that this was going to be a conversation we had in regards to children who are no longer being able to access the one safe adult in their lives. 6 months ago, we wouldn't have known that there was going to be some impacts in regards to the experiences that adults were having in regards to their own chronic stress. That when we look at these vulnerabilities, and again, this becomes an important piece too, and this doesn't necessarily have to do with complex PTSD, but when we start to understand the relevancy on, so why is it tolerable for some that we're in the middle of this pandemic, and for others it feels toxic? Aside from the children that maybe have been put in environments where there's much more, increased levels of toxic stress, again, unemployment, underserved communities, food scarcity, all of these, other impacts. But what we're also looking at is individuals who, if they had, so they are currently adults, we can look at this in regards to first responders, which we have seen this as well. We can look at this in regards to adults who maybe have had a different childhood, that if they had experienced toxic stress when they were younger, domestic violence, abuse, neglect, substance use within the home, mental health within the home, if they experienced this as a child that they had not readily dealt with, then as an adult, their vulnerability to the impacts of this pandemic increased the vulnerability to them experiencing this as more toxic than tolerable. So hopefully that makes a difference. And then when we look at secondary and vicarious traumas, I'm not going to necessarily go into that, but it becomes an important piece of recognizing, I use the phrase all the times, we are humans treating other humans. So it becomes important for us to recognize that in our careers, that some are going to be more susceptible to the experiences of others. So as secondary and vicarious trauma, I do a lot of work with first responders as well. And so when we're looking at that vicarious trauma, secondary in regards to their experiences to what they see and witness. When we're looking at those that go into the helping field, who might also have had their own experiences with adverse childhood experiences, that they might have an increased vulnerability to experiencing secondary or vicarious trauma because it's initiating some of the same response systems, that fear response system. Before we get into kind of the meat of it, I found some of these quotes, and some of them are from those that I had worked with, that I think it's important. So I can give you the definition of trauma, right? We're going to go over the definition of PTSD, but I think that it becomes important to just recognizing kind of what is it, not in the, in the definitive, criteria, but what is it? So these were some of the phrases or some of the quotes that I liked in regards to understanding its impact, right? So trauma is the emotional, psychological, and physiological residue left over from the heightened stress experience of threat, violence, and life-changing events. And again, we're going to talk a lot about the brain and how it adapts. What I want you to continue to hear is that not that this is something of like, wow, all of this happened and that's how somebody is. I want you to keep in mind that strength-based lens, that when we understand something, that we have the capability of helping somebody to understand themselves, that people can and do recover every day from their healing experiences, from any traumatic events that might have occurred to them, as well as from substance use, but that we have to reduce stigma because we know that there are a lot of individuals. So research is varied in regards to the extent. Again, I work in a treatment facility every single day. I'm going to argue that there's close to 80 to 90% of our patients are coming in here having experienced some sense of trauma, traumatic grief, traumatic events, traumatic childhoods. And so it becomes important for us to recognize those vulnerabilities so that we're not condemning or shaming somebody for the experiences of how they figured out the best way in the moments to cope. That when we talk about Bessel van der Kolk, so if you are looking to get more information on trauma, that's a great, The Body Keeps the Score is a terrific book. It's a wonderful, particularly if you are more of a science-based person and research person. He does a lot of really great work in regards to the research associated with trauma. And so he had identified trauma as an inescapable stressful event that overwhelms people's coping mechanisms. So again, when we try to break that down as to what does that mean, he's talking about the physiological experience, that something happened that overwhelmed somebody's ability to cope. So how did they end up using substances? Because in the moment where they couldn't manage themselves and their experience, the substance worked. That when they didn't know how to cope with it, the substance worked. So, and again, we'll talk about that as we go through that. That here's some quotes from some children and a mother that I had worked with. So if you knew her before all of this happened, you would know that she is not okay. As a mother, you would know that she's still hurting. So this was a mom that was talking about some of the behaviors that her daughter was coming in contact with the schools and the authorities. And what she was saying is that if you knew this before what had happened to her, you would know that she's not okay. Because you would have known who she was when she was little. I don't know what that feed is. If somebody's able to recognize it. There's some feedback. Is everybody hearing that? Karina, it might be you. If you're not on mute, I can hear me through you.
Okay, I just was going to let you know we did have one question that explain exactly what toxic stress is. She said, is it like stress that you function through knowing that these or this stressors are there, but you still move forward without dealing with the actual stress? It's like a buildup of objects on a plate.
So,
I'm sorry, I meant tolerable stress. Sorry.
Oh, tolerable. Okay, I was going to say. So tolerable stress is kind of just the stresses that we all experience. You know, stressful events in your life, if you're having a hard day at work, you know, if you have a lot of pressures that are being put on you in work. So it has the potential to negatively affect you. But when you have some of these other things in place, that you're able to moderate it. So tolerable stress, again, is able to be, you know, I think of like, and again, this is the easiest way for me to kind of recognize it is that if you're working a job that has become more stressful or somebody's put additional demands on you, it becomes tolerable because your stress system is responding and you feel it and you're managing it, but that it doesn't end up converting itself into toxic because you have some of these offsetting resources to you that it doesn't then consume your physiology. So it can look the same, but if you don't have outlets that are helping you to mitigate the experiences of it, and it's also going to be, it's not forever. So I'm hoping that I answered that question in the best way that it was asked, if I understood the question clearly. So if I didn't, then just please feel free to send it back in. So that's kind of the difference between the two. So for a 7-year-old little girl that I was seeing, and again, I'm not going to get into the differences, but this was a little girl that was coming to me who was being diagnosed with ADHD. I do specialize in ADHD, so that's why she was coming. She was having issues in school. She was also behaviorally acting out in school that they were kind of diagnosing with the ADHD. And in sitting with her, she started talking and she was drawing pictures. And she said, this is what she does at night. Every night with her family, she sits down and she says, if we pray, we don't get shot. So whether or not she identifies that as traumatic and the verbiage that her family is providing her, it's certainly going to be stress. Because every day she's associating now that if she doesn't say these prayers that she's going to get shot. And that for this last child, again, who was coming to me because of the behavioral issues that they were identifying, I'm angry all the time. I hit and I scream because all of this stuff, and I'll be thinking in my head, why did this stuff happen? So all of the things that we're experiencing, and again, it becomes incredibly important because we oftentimes focus in on the behavior, but not the why is this child behaving this way. At 8 years old, every child wants to do well. So when you see a child throwing a desk, when you see a child that's constantly fighting, when you see a child that is chronically disruptive, and again, we will talk about it as we get into more of the understanding of the brain, it becomes incredibly important for us to recognize, how did we get here? What is going on? That this is the coping skill that the child has adapted. That's the big question, right? Because we all have some levels of stressors in our lives that we have to learn coping mechanisms. But when trauma happens, as Bessel van der Kolk had mentioned, it overwhelms their coping mechanisms. It takes over the part of their brain that allows for them to make the right decisions. So how do we get them to utilize the part of their brain that will help them move forward? So I will say this, these are going to be the diagnostic criteria for PTSD. I normally don't ever go over the diagnostic criteria for PTSD because I feel like people can read it. Having said that, I'm not going to spend a ton of time on it. I'm just going to kind of highlight, again, the DSM's diagnostic criteria. The reason why it's in here, and I normally don't, I almost never have the diagnostic criteria for PTSD in my trainings, again, because you can read them pretty independently on your own. But I think it became important for me to add this because when we start to look at, when we talk about complex PTSD, when we start talking about complex or developmental trauma, we really are looking at children. And historically, it's harder to identify. And we have come a long way in the last, several years in having a different way and a different framework. But many children won't meet the criteria for PTSD. So the criteria is relevant, and it's certainly important in us in identifying and creating interventions and strategies to help somebody. But for children, they oftentimes don't meet it anyway. So we're going to spend a little bit more time in kind of sifting through the complex nature of it. But what would need to happen is that these stressors, right, a traumatic event. And so when I had said before that sometimes it's difficult to diagnose, is that when you're talking about some children that are living in environments where it's chronic in nature, the experiences, the stressors, they won't have said any of this happened. I didn't have a traumatic event. So they might have witnessed some things, but it didn't feel like it was an event. It's just, every day. So again, I utilize a little boy that was being diagnosed with ADHD and oppositional defiant disorder. I believe he was 6 or 7. And when we started speaking about it, so he did not have a diagnosis of PTSD. He had a diagnosis of ADHD and oppositional defiant disorder, right? He was being punished. When we started talking about it, this wasn't an event, and I'm not sure if he was in a foster care system. I can't remember who was there with him, but they were saying nothing is happening to him. There's no death, but you listen to his stories, and it was similar to that little girl. The normalcy to, I just pray so I don't get shot, that he was saying, I see things when I walk, to my bus. I'm scared when I get on the bus. When I get on the bus, I see people getting hurt. I see people that are getting beaten up. I've seen drug deals. I've seen things. I saw a person that was in a car, and the car was on fire. And so he says it matter-of-factly. So it's the pervasiveness that starts to change it. So again, when we're looking at the diagnostic criteria for PTSD, according to the DSM, right, the intrusive symptoms, the intrusive memories, the nightmares, the flashbacks, the emotional distress to triggers, the physical distress to triggers. This is harder to, again, identify with a child. And depending on when the trauma occurred, it's hard for the child to even identify it. So again, when they're pre-verbal and the trauma was occurring even then, they actually don't have language to describe what was going on in their lives. So does he have intrusive memories? No. He's not having flashbacks. He's not having, nightmares regarding it. He's just at a chronic heightened sense of awareness. He's extremely hypervigilant. So his symptoms look different than what would be a normal diagnostic criteria for PTSD. The avoidance, he can't avoid. He's a child, so he has to go to school. He has to go on the bus. He has to get into, he has to walk the streets to get to the school bus. So all of these things he's not avoiding, and he would need one. So the avoidance of the trauma-related stimuli after the trauma, is he avoiding certain people, places, and things? No, he's going. He's not trying to avoid certain thoughts that he can verbalize because he's a child.
Trish, we did have a question asking if divorce is traumatizing for children. If so, if you could explain how and why.
Sure. So I'm going to go back to kind of when we looked at the different stressors. So is divorce a stressor? Yes. Where does it become tolerable versus toxic? I want you to look around into what is going around in that environment. So there are those that have gone through a divorce that it's been tolerable because there hasn't been a history of trauma, because they have supportive adults in their lives that are helping them to manage the divorce and manage their experiences. So it's definitely a stressor to a child, as it is the entire environment. Any kind of change in the environment is difficult and stressful. But does it become trauma if it becomes toxic? If the parents are chronically fighting, if the child is constantly in the middle of something, if the adults aren't available to support the child. So if the adult's divorce is where the mother or the father are left overwhelmed with their own emotional experiences. And again, we can start looking at generations of why do some people manage it differently, right? So again, we have all of these reasons that when you start taking a trauma lens, you can go all the way, as far back as you can see some of the behaviors. But if we're focusing on a child in that moment, divorce in and of itself is not traumatic. It's stressful. It's the environment that's around it. Is it a supportive environment? Are there other caregivers in that child's life that can create stability and safety? Do they have grandparents, teachers, siblings, aunts and uncles? Do they have family friends that provide safety and stability? Do they have a safe place to be able to express themselves when they are tearful, when they're sad, when they are upset, when they are angry? Do the parents have some stability in their ability to support their children through the divorce? Those are the differences in what becomes tolerable versus toxic. So hopefully, and that's where that fine line is, right? When you're like, well, how come it was traumatic? Because we work with some people in my facility that have said the divorce was traumatic. They'll identify it as that was a traumatic event in my life. When you pull it back, what was traumatic about it? Mom started using substances. Dad never, I never saw dad again. I became my mom's caretaker. There you go. That's when it crossed over to toxic. Because the child in that moment, the fear response system is going to be alerted, right? It is going to. A divorce happens, everybody's fear response system is alerted. It's a change in the environment that's stressful, and you have to assess it. What's going on in my life? How do I assess this? Is this going to be safe eventually, or is it not? So when somebody says that the divorce was traumatic, it's normally beyond just the divorce. So again, hopefully I answered that question. If not, please poke it back in. When we look again at that continued criteria for PTSD, the negative alterations in cognitions and moods. And so again, then we're looking at some of the negative affect and the feeling of isolation and the decrease in, and activities, the anhedonia, the exaggerated blame around the trauma. So I want you to keep paying attention because, as I said, developmental trauma can occur into an adult. So some people don't have this language. Some people can really access it and identify it, but some just don't have the language. And some people as a child and then grow into an adult, they don't know how to say, I'm exaggerating this blame on the trauma, right, towards the self or the others. This is all my fault. So you're really having to pay attention to stories. You're having to listen to the stories where, who held you? I mean, I remember asking that question all the time when they were younger to kind of assess. They didn't realize that I was doing that. But I would be asking questions and just saying, listen, do you remember when you would get sad when you were little? Yeah. So when you would get sad, what would you do? I don't know. Sometimes I'd get angry. Sometimes I get sad. Or sometimes I would, go by myself. And then I would say, who held you if you cried? There you start hearing a difference. Right? Nobody held me. How come? I don't know, because crying is for babies. Now I'm hearing it, right? That at a very young age, I'm starting to assess the difference between tolerable and toxic stress. That at a young age, I'm listening to somebody describing that they had a primary parent that was also not capable of nurturing. Not because she didn't love him, but because she didn't know how to do it. So now I'm looking at multi-generational, right? So all of those things start to interplay. Diagnostic criteria for PTSD. And again, they've done a lot of work with revamping this, and the most recent DSM, for those of you that have been in this field for a long time, the criteria was very different in the past. And so they have tried to adapt some things to be able to identify behaviors we might see in children. So the anger and the irritability, the risk-taking behaviors. So when you see promiscuity, when you see more, interaction with substance use and those kind of risk-taking behaviors. The hypervigilance is pretty chronic, although, again, it can get over-identified with ADHD. The anger and irritability can get over-identified with ODD. The risk-taking behaviors, again. So, again, for those of you, there's a lot of you on this line. I don't know where everybody is coming from, but if you are in the Child Protective Services, if you are working with children and adolescents, I will caution you and encourage you to pay attention to the trauma, because oftentimes, and I'm not attempting to try and have a different conversation in regards to the training, but in my experiences, what we see is that there's certain communities, underserved communities, that are disproportionately being identified with oppositional defiant disorder and conduct disorder, which is a precursor for an antisocial personality, which is a precursor for the prison system. If we identify this as trauma, not conduct, then we have opportunities at a very young age to make a difference in a child's life, to treat the symptoms of their trauma, because this is a safety issue for a child, so that you can quit feeding into that pipeline of oppositional defiant conduct disorder, antisocial personality, prison. So there's opportunities to assess appropriately. So gathering a full story, hearing it, whether or not somebody comes in, almost exclusively, the children that I worked with did not have criteria for PTSD. But yet almost all of them had trauma. So healing the trauma will help them to increase the behaviors that they need to succeed in life. When we start looking at childhood trauma, child abuse, including physical or sexual abuse and neglect, is one of our nation's single most important public health challenges. That when we talk about the adverse childhood experiences, and Dr. Nadine Burke-Harris, who has, created her own opportunity in the Youth Wellness Center in California, doing amazing work in trying to help with this, this is a public health crisis. And there are more and more schools that are becoming trauma-informed and recognizing the significance of childhood trauma in the way that we are looking at how to treat these children. But it is a public health crisis because when I get to that adverse childhood experiences, you're going to see not only the mental health crises and the substance use increasing, but you're also going to see these physical. So there's a significant push in addressing the childhood experiences, looking and assessing them from a medical standpoint as well as a clinical standpoint, so that we can appropriately heal somebody so that they have the capacity to be their best selves. Because when we discipline trauma, and this is an interesting thing to keep in mind, if we understand that children that have experienced trauma, that this is a safety issue, and again, I'm going to talk a lot about the brain and its impact, that this is a safety issue. When you try to make a child feel safer through punitive means, imagine its efficacy. But that's what we're doing. A child that does not know how to feel safe in their own skin because it has overwhelmed their ability to figure out appropriate coping skills is met with punitive measures to have to manage it. So you don't feel safe. You just feel more vigilant towards not wanting to get into trouble. So again, when we start looking at it again, over 300,000 children are reported to the authorities for abuse and neglect. For those of you working in the child welfare system, you know that this is increasing as a result of this pandemic, but there's underreporting, so there's significant concerns because when the pandemic happened, there was less people that were getting into the homes and children were getting out of the homes less frequently. And so the stressors that are associated with what was happening to some of these families was increasing some of the violence. 60% of adults reporting experience abuse or other difficult family circumstances during childhood, right? So we're looking at 1 out of 5 witnessed violence in their home or their neighborhood during the previous year. And most trauma begins at the home, and the vast majority of people responsible for child maltreatment are their own parent. And we're going to talk about the significance of that when there is abuse. And again, I'm going to keep having you refer to when there's an adult in the child's life, if something traumatic happens to somebody, but there is the structure and the environment for support, there is resiliency that can be built. If it is at the hands of the person that is supposed to be the one caring for you, it changes the way that the brain sees the world. So when we start talking about complex PTSD, this is more involved form of PTSD that may occur in people who repeatedly experience trauma. So we're looking at the traumatic stress field is adapted. So again, this is where they have looked at, we got to look beyond general PTSD to describe the experiences of multiple, chronic, and prolonged developmentally adverse traumatic events. And when we're talking about that, when it's at the hands of somebody that's supposed to love you, most often of an interpersonal nature and early life onset. So it's when it's occurring at a formative time of life by the person that's supposed to care for you. Results when a child is abused or neglected, but also can be caused by other events such as domestic violence and community violence. So again, we are looking at this. And again, I'm not going to have significant conversations, but it is important enough for us to recognize that community violence, that the social unrest that we're experiencing right now, that when we're looking at the communities being impacted, if we are trying to have a strength-based lens, if we are trying to identify compassion as opposed to judgment and stigma, then we need to recognize that those experiences inside an environment or a community where they have been riddled with violence or riddled with not being served or a lack of fairness and opportunity, that we have identified that that in and of itself is traumatic to the upbringing of a young brain. So when we want to look at how do we heal it, it's about healing the community. It's about empowering the environment. That's how you solve it. Punitive measures don't work. Not in this example. Typically, complex trauma interferes with the formation of a secure attachment bond between a child and caregiver. So this is where, for as many years as I've been in this field, the number one telltale sign is when somebody says to me, I don't trust anybody. Okay. I almost don't even need to ask any other questions to know that there has been some level of complex trauma in this child's life, that's the lesson. Hesitancy, sure, but if you were raised in an environment where your needs were met, you didn't change your schema that the world is unsafe. So a child that feels inherently that anybody is a potential threat to them has likely had a different life experience, that's what they've taught. And again, the closer you are to the person that's supposed to be your caregiver, and I'm not throwing any shade or any judgment on the parents either, because again, oftentimes you're looking at multi-generational trauma, that if this is what's passed down, then why would we expect somebody to be able to do something different unless we intervene and provide additional support? But if the person that's supposed to provide you the most safety isn't capable of doing so, then how would that child think that the world is a safer place? You know that the world is a safe place based on the environment that you were raised in. So these exposures occur within the child, oftentimes within that caregiving system. Dun, dun, dun. So I kind of just said that, so I'm not going to go over that slide. So what are some of the symptoms of complex PTSD? Again, you're going to see some of the same symptoms that you would if you had PTSD, but what you're going to see that's going to be a little bit of a differentiator is that you're going to see these changes in their beliefs, right? When they don't think that the world is safe, when everybody's out to get them, that kindness is for, losers, that if you show kindness, that you will be attacked or you will be exposed as weak. Now you're looking at schemas. You're looking at changes of experiences. But they might have these kind of disturbing thoughts, revenge. So this is, again, that teetered line where people will say that they're going to be, this is conduct disorder, that a thought doesn't mean it's an action. It means that somebody doesn't know what to do with it. So I've worked with a lot of people that I actually worked with a young man that had been shot. So he was working with me. The sad irony of this is that he was working with me based on the complex trauma that he had experienced at the hands of his mom, whom he was still living with, who did love him. So we were working through some of his trauma, and he went to get pizza and he got shot. Calls me from the hospital to tell me that he's not going to be in his individual session. And then when he came to start coming back to do his session, his mind was full of revenge. He was full of rage about what he wanted to do to this person that had shot him. He didn't even know who it was. It was a random shooting. But he was full of rage to them. He was full of rage at the hospital, who treated him as if he had deserved it, as if he had been, not that anybody deserves anything, but they literally treated him as if he had been a part of a gang retaliation for this young man that was not even involved in gangs. Not that that is an excuse, but he had all kinds of revenge for that. Those are the disturbing thoughts. That's the complex PTSD. He's not going to do any of these things. He's fantasizing about how he can cope. He's trying to figure out, his brain is trying to figure out how to make sense of this, but he's trying to live it out. Normal. Changes in their their concepts, so they might feel guilty or helpless. So again, the irony of this, for this young man, he was feeling incredibly helpless. He had been frozen as a child, so he did not fight back to his mother at the hands of her abuse because he froze. And so he had tremendous guilt and shame of why wouldn't I have fought back? as a 5-year-old, a 6-year-old, a 7-year-old. So then this happens to him, right? So the concept of what he was trying to do, and the interesting irony is that his trying to get revenge was him actually trying to move through his trauma. He's trying to fight because he was stuck in freeze. Here's an opportunity. He's trying to fight back. And so we're trying to figure out ways that he can appropriately do so. The emotional changes, so again, extremely angry, repressed, depressed, sad, or suicidal, all of those things go hand in hand. Sometimes you will see the self-harm. So what are some of the risk factors for somebody to develop complex PTSD? It's going to be childhood abuse, childhood exploitation, domestic violence, concentration camps, wartime imprisonment, trafficking. All of these things increase the likelihood of somebody developing that. And then some things, again, that can make it more severe. Again, the younger that you are when it happens, the younger as your brain is developing, your brain will adjust to the experiences. When it is at the hands of a person, a parent, or a trusted adult that was supposed to be in your life, providing you safety. And when the person responsible for the trauma is still in contact. This is when it becomes difficult, because you can have family members that do genuinely love their children, but are the perpetrators of the abuse that they've endured, but they haven't. So again, there's a lot of interventions, and I appreciate that Dr. Nadine Burke-Harris, that when she's saying, how do we reduce these adverse childhood experiences, she's like strengthening the family. I'm not always going to just take the child, although I might have to for the safety of that child, but I'm also going to then work with that family to help them, because this is a family that oftentimes might not have learned these skills as well. So again, if it is left untreated, the person responsible for the trauma, when they are still in contact with the victim, that those symptoms are going to perseverate. I'm going to go over a couple more slides, and then we're going to take our break right at 11 o'clock. So trust within a traumatic world. So when we're looking at the child, when a child's love or sadness is mirrored in the face of a parent, and there's a great experiment that was called like the mirror experiment. So you can Google it. I don't normally show videos when I do these things. The child experiences comfort and trust within the caregiver, right? So it's our mirror neurons. We reflect back what we see. A securely attached child by 6 months of age will demonstrate confidence and have freedom to express his emotions. However, when the child experiences unpredictability or dissonant emotions from an adult, where they cannot show mirror neurons, or there is a harsh or an overwhelming response, the attachment to the caregiver may be characterized by distrust, fear, disorganized, or conflicting feelings. So when the caregiver is inconsistent, it starts to thread through that the world is not trustworthy. So when we think about the concept of how somebody develops trust, and this becomes incredibly important because we work with a lot of adults that don't inherently have trust. So when we recognize where it stems from, then we have the ability to start helping them, because to me, one of the things that we get stuck with, and especially in an inpatient facility, is we can overinflate our importance. So we have somebody that has inherently demonstrated that they do not trust individuals. But we need trust within human connection. So then they meet a therapist in a short-term level of care who demonstrates the skills that trust is possible in this world, where I can be vulnerable, where I can have consistency with my expectations. This is why when staff members are inconsistent, you will see the significance of the behaviors of that patient, because it's going to be reflective of their early childhood experiences. But when staff is consistent, when staff is responsive, that patient will identify only trusting that one person, which is fantastic, because it's showing, again, the plasticity of the brain. This is movement. But when they don't work with that person of helping them to identify what they are experiencing as trust, the patient will only identify that person as trustworthy, not that they have the capability of helping to identify how to find trusting relationships. And so then it becomes a part of the relationship where they almost need that person and that therapist. And so I'm always careful with, we don't want to perpetuate the behaviors that we're trying to treat, that if they think you are the only person that's trustworthy in this world, the only way they can keep getting you when they are vulnerable is to continue to have reoccurrences of their disease. They have to continue to use. So having some of these conversations becomes incredibly important because we know that their trust is going to be impacted in a traumatic world. All right, so why don't we take our 5-minute break? It is 11 o'clock. We will come right back at 11:05, and then we'll talk about the dynamics of childhood trauma. If you have any questions, feel free to send them in now.
So I want to welcome everyone back, and I believe there was someone on the panel who had requested to revisit the slide on risk factors. So I do have that up for you to view briefly. And Trish, we do have a couple questions if you are able to answer those.
Absolutely.
Absolutely.
Okay, so the first one is, are there any current studies on trauma at this time? And that person would like to volunteer on those studies.
So I'm sure that there's always consistent kind of research doing on traumas. I don't know of any current, I'm not fully aware of where. I mean, there's some, relatively, typically you're looking at like research universities, or you're looking at some of the organizations that are working more intensely, so community agencies that are working more intensely with trauma. So I don't know, again, depending on your area, if you're wanting to get involved in research, I would probably search it. I don't know, again, I don't have specifics as to who's doing the current research. So that I apologize, but there's definitely research that continues to go on in regards to trauma. What was the other question?
Would you speak on how once the client relates, trusting the therapist, and then how the therapist can facilitate with the client into trusting others?
Yes. So the whole idea, so us as a therapist, and again, this is kind of like the world from substance use, but we always say, because, in the substance use world, we have individuals that we encourage them to get sponsors. And part of sponsorship, they have a phrase that they say, my job is to make myself as irrelevant in your life as possible. Meaning, I come into your life because I'm serving a purpose. I'm helping you to sustain recovery. I'm helping you to build your recovery skills so that you no longer need me. And I thought, how profound that sponsors are aware and recognize that they can't be the lead actor in somebody else's play. And so for therapists, I think this is a wonderful opportunity, particularly, again, depending on where you are in your level of care, the significance of how quickly it's done. But when you're working with patients, and again, if I'm going to be completely transparent, right, and honest, it's that sometimes we feel good about being that person's only, trustworthy human being. There's something that inherently makes us feel like, proud about it. And there's something wonderful about it. What you have done is you have mirrored a relationship that this individual is looking for. You are letting that person know safety does exist in this world. How you then utilize that information is by allowing that patient to recognize it isn't me. And so I'll, give you an example of, the relationships that I've had is, when they would say things like, Trish, you're the only person I trust. That while I would recognize and validate that experience, what I would say is it possible that it's not me? What is it about me that allows you to feel safe, allows you to feel comfortable, whatever the language is that you would be able to utilize with your patient? Because the trust is actually in you. I'm providing an outlet that when it is presented to you, you have learned to trust it. So what about me feels safe for you? And that's where they start to identify, well, you listen to my feelings. Okay. You are, you're not reactive to me. You don't judge me. They start listing what it feels like for them in a world to feel somebody trustworthy. I'm consistent. I do what I say. And then we start to say, how else can we include others in that circle? Because I won't be here forever. And I don't want you to think that your ability to find trust is because of me. You have found trust in me, but that means you have the ability to establish it. I just became the vessel. So it's helping them to recognize, what about it? What about us feels safe for you? And then where else can we look? Can we identify sponsors? Can we identify community organizations? If you're working with children and adolescents, can we identify peer mentorship? For young adults, we had an organization in this area that had, this like peer mentor that they could do resumes, all these other things. And I was like, can we start to build your network so that you have multiple areas in your life where trustworthy people are around you? So it's validating that they're identifying it. That's the brain, right? The brain inherently did not trust anything. You are recognizing that they are progressing because they trust you. Now I want you to help them to recognize, what about you? What about you is offering this to them, because that's what they get to keep. And now let's look for it outside in the world for you. Who else can we pull into this? A pastor, a priest, community organizations, all of these things. It can be family, and that if you have family that are still invested and have done their own work or aren't the perpetrator, that you can have the family come in for a session to say, these are some of the things they're looking at. Are you able to offer this to him or her? If they get dysregulated, if they get upset, how are you able to manage them so that they can continue in this exploration of identifying trustworthy human beings in their life? So hopefully, again, oh, look, somebody posted that. Clinical trials may list some active studies involving childhood trauma. So thank you, Kathy. That's wonderful.
Okay, we have another question. As mental health providers, there are times when we are the first individual the child becomes vulnerable with and trusts. With that, the children disclose abuse that they endured, and of course, as mandated reporters, we report. The child knows it is because they only shared that information with us. We become another person that they can trust. How do providers work around that and ensure the trust is not lost?
That's a really important question. Because as mandated reporters, we are responsible to ensuring the safety of a child. And so I think that when those things happen, again, in transparency, that it's opportunities to share with that child, because they will say, and again, in a different situation, we had a young woman that was in our treatment facility. We had to increase her level of care. She was so upset and was like, I trusted you. I told you things, right? That I had to stay consistent and present. That through her rage, that she felt she trusted me in sharing these things, I still had to do what was in her best interest. And so all I can say is that I didn't, and this is an important piece, what I say to most children or any adult, and this was an adult, right, a 23-year-old, I'm always going to work in the best interest of who you are and in your safety. And so if they feel betrayed by it, that my consistent messaging is, I always said I was going to work in the best interest of you and your safety. And so there's opportunities that I have to do what's right, that I'm not betraying your trust, but I'm making sure that I continue to do what it is that I said I was going to do. Your safety is always going to be my priority. I'm always going to be advocating for you. And that way your words are not, but the child, expect the child to be dysregulated. Expect the child. This little girl cursed me out, screaming and yelling. And then when she got the treatment that she needed, and she doesn't owe me anything, right? I don't ever ask for anything. She wants to apologize because she was allowed to experience the behaviors of just the circumstances of their lives. That if you continue to be a safe adult to them, that you will be transparent with your experiences, you will be transparent with what you are doing, and that you will allow and tolerate the behavior. So I hate you, I can't trust you, you never, I'm never going to trust another human being again. That you remain the same person you were before you disclosed any of that information. You remain the same person that you were before you had to report. That's what trust is. I'm doing what I said I was always going to do, and I'm going to continue to be here for you as a support. That's trust. And if the child is angry and yelling and cursing you out and upset, of course they are, because they are living the experiences of their lives. They're manifesting their symptoms of feeling overwhelmed and overregulated. It makes sense. And so I'm not upset at that. And I validate it and I understand it. So again, hopefully that kind of makes sense. It kind of does tie into this idea of the dynamics of childhood trauma, that if the caregiver is exposed to unmanageable, or if the child is exposed to unmanageable stress and inconsistent caregiving, the child will not be able to organize and categorize in his or her experiences, right? Changes the schemas. It is that idea of kind of like the Harlow monkeys, right? So in the presence of safety, all animals, including humans, return to what is called exploratory orienting responses. Curiosity is a non-traumatized body's natural movement outward and is motivated by the desire to explore its surroundings. If that is compromised, then you will see a child that is afraid of exploring, afraid of an environment, because they haven't learned that the world is safe.
Can you please say again how to prevent dependency during treatment? I guess identifying for the client their healing behavior.
Yeah, so, you know, again, I think that what you're able to do is help the individual recognize what it is that they are identifying with you. So when they are saying, I only trust you, they have identified qualities. So you're starting to create the schema. So that's normally what's done in a household that there is no trauma. If you were to ask your own children, if you were to ask other children that have not had that, what does trust feel like? They're going to describe it to you, right? When I cry, I go to the same person. You know, mom always tells me that she loves me, yada, yada, yada. They're going to describe to you what trust that word means. For a child that has been traumatized, that does not know how to trust, when they start to display that they do with you, helping them to then be curious about the world, right? So that's kind of what that Harlow's monkeys is. If you don't have a safe environment, you don't kind of go out into the world to explore. They are now creating opportunities of understanding what trust can feel like. It's possible. Maybe prior to you in their lives, it wasn't possible. Maybe they never had somebody they fully could trust. And so here's an opportunity for your relationship where you've identified, you've become the surrogate adult that has provided them the stability, that despite their behaviors, cursing you out, being disruptive, all of these things, that you've remained consistent for them. So helping them to identify what about me has allowed for you to start feeling like you can trust me. So it's really just helping them to own it, that the work was actually theirs. You were just you. So how did you know that I was somebody you could eventually trust? Right? And that's that piece is you were just you. You might inherently be a trustworthy person, but for them to trust you means that they started to take risks. There was something they started to trust in what you were presenting. So how do they take that coding to then identify it with other people? I normally will start with people that I would identify as safer. That's where I'm normally, you know, interested in identifying community resources, you know, depending on the ages of them, you know, other people in, you know, in the field, you know, a sponsor, different things. I normally won't look at like intimate relationships. How do you do that? If I had the parents involved, I could do it with them. I could help the family recognize what the child was identifying as trustworthy to help the family. Again, that's the beauty of what Nadine Burke-Harris talks about is like I am empowering the family to reduce their ACEs. So you have opportunities to do that if you have a family involved. Can you bring them in and get them involved? But otherwise, we're looking at other safe adults in that person's life to help establish that. In the adult world where we are substance use, we're looking at alumni. We're looking at sponsorship. We're looking at 12-step fellowship. We're looking at having them establish themselves with other relationships that would also serve to be trustworthy, allowing you to feel safe in that environment, not judged, not shamed, not stigmatized. When we talk about love and neural connections, again, this idea of the use it or lose it concept of the brain, the neural circuitry that gets strengthened is the circuitry that is wired. It is not decided upon as good or bad. It's decided upon what works and what doesn't. So the use it or lose it, if you are surrounded in an environment where your nervous system is constantly aroused, then the part and that fear response system is significantly triggered, then what will happen is that the other coping skills, the safety, those kind of things get pruned away. The neural circuitry for that would get pruned away because like your, you know, again, your brain, similar to a muscle, whatever you're working out gets stronger and stronger. So for children, that fear response system gets stronger and stronger. So again, if you feel loved and safe, your brain becomes specializes in exploration and play. You start looking for other people in your life. You feel content. If you feel frightened and unwanted, these neural circuitries specialize in managing fears of fear and abandonment. So they are constantly assessing for those two things. When we talk about the adverse childhood experiences, and this is where, so I'm going to move through some of these slides. This is kind of where we talk about it in regards to substance use and any of the other long-term consequences, is what are the adverse childhood experiences? This was a research that was done. It was a little over 17,000 people that they had done this test with. Again, Vince Felitti and Kaiser Permanente did a study. And what they identified was that the higher the risk score, so prior to your 18th birthday, did any of these occur? Out of 10 things: physical, emotional, sexual abuse, physical, emotional neglect, domestic violence, incarcerated household member, or biological parent lost to divorce, abandonment, or other reason, alcoholism or substance use, mental health. That for every one thing that happened in your life, you scored a 1. And the higher your scores, the higher your risk. So when we start looking at what are some of those risks, and again, this is kind of just a breakdown of a study, 17,000 people, what they identified was that the higher the risks, or the higher the ACE scores, the higher your risks. So for health risks, for somebody that had 4+ ACEs or more, 2 times more likely to smoke cigarettes, 4 times more likely to have depression, 7 times more likely to have an alcohol use disorder, 10 times more likely to have a substance use disorder, including injection, 12 times more likely to attempt suicide. Health outcomes, so again, when people were not certain that, are we just condoning this whole trauma theory and, this seems silly, what they identified is that there was health outcomes as well. 2 times more likely to have ischemic heart disease, the #1 heart killer in the country, 2 times more likely to have cancer, 4 times more likely to have bronchitis. So what they were speaking to was the changes in the physiological experience of somebody that's had significant trauma throughout their childhood. And again, so ACE score 4+, 12 times more likely to have a substance use disorder. Domestic abuse was 5 times more likely, 8 times more likely to be victimized by rape. And when we start to look at 6+, 7+, and 7+, then we're looking at substance suicide attempts, 51 times more likely for youth and 30 times more likely for an adult. So what we were identifying, or what they identified in this research, was that the physiological components of trauma change the physiology to the experiences of somebody's developmental growth. If you would like, so if you want the ACE studies, I think it's one of the best TED Talks you're going to be able to see. Is all you need to do is, I'll put it in the, I don't know the link, but Nadine Burke Harris TED Talk. So if you Google that, it's going to pop right up. She does a TED Talk and she talks about the neurochemistry and she talks about the ACE studies. To me, it's one of the best videos that you can have yourself grab and watch. So now we're going to spend a little bit of time talking about the neurobiology of brain development. So I want to start by, again, saying kind of the brain develops from the bottom up, that when we're looking at how the brain develops, this is where that important piece starts to come into play. That the brain is always comparing current incoming patterns with previously stored templates and associations. That's how our brain operates, right? And again, I'm going to get to that whole idea of the bottom up. This matching process takes place initially in the lowest, simplest part of the brain, your brainstem, where the neural systems involved in responding to the threat originate. So all the way at the bottom of the brain is where these threats start to originate. As the information moves up from the first stage of processing, right? So again, moving up towards the limbic system, the brain has opportunities to take a second look at the data for more complex consideration and integration. So how do I make sense of the stimuli that's coming in? The loud sounds, kids laughing, a sound outside my window. And again, this is why there's so much context into when somebody hears a loud noise, their response system. So as it's moving up, it's starting to kind of assess, is this information potentially dangerous or not? If the experience is familiar and it's safe, the brain's stress system won't be activated. So the limbic system will be like, nope, we've assessed it, you're good, keep moving on. However, if the incoming information is initially unfamiliar, new, or strange, the brain instantly begins a stress response. The amygdala immediately starts, which is in that limbic system. How extensively these stress systems are activated is related to how threatening the situation appears. So it becomes really important for us to understand that our default is set at suspicion, not at acceptance. So we are organized to survive. So our default is to pay attention to a sound. Again, you hear a loud noise. Your brain immediately says, that's suspicious. Let me assess it. Nope, we're good. And then you start to slow it back down. However, if after your brain continues to evaluate this information, your brain may recognize that the new pattern of activation has been caused by something familiar, but out of context, right? So again, you're in the library, you drop something, you hear a noise, it's immediately going to increase your heart rate. You're immediately going to feel that. That's that whole like, woo, that scared me. But it won't say that's anything to worry about. Then it recognizes it. It says that's fine. Boop, put it off. But if you were to hear that same noise, and then you turned around and you discovered that other people around you seem also alarmed, this is the importance of your organization. So when I do trainings inside my own organization, I always say, we are all the captains of this ship. So if you look panicked, they will be panicked. And it doesn't matter your role. If you're housekeeping and you look panicked, the patient's panicked. If you're the CEO and you are panicked, the patient's panicked. If you are the therapist, it doesn't matter. Because if they start to look around and you see other people alarmed, then you start to initiate that fight or flight response system. So that fear response is graded. It's calibrated in the brain's perceived level of threat. That's the limbic system. So first, your brain makes you stop thinking about irrelevant things and shutting down the chatter of the frontal cortex. So again, if we think about how a child is developing, or even an adult, when we're asking somebody to do something rational, right? It was just X, Y, and Z. It was just a loud noise. It was just a book. The reality is that if the child's fear response system is activated, or again, it can be an adult, I'm using the child, that what will happen is that it will actually shut down the cortex, because it doesn't want the cortex, because it needs to only assess for things that are survival related. So math isn't a survival skill. Reading, not a survival skill. All of the non-essentials get actually removed from the experience of the brain in that moment, so that it can only focus on the cues from others around it to determine who is a threat and where is it safe. This is when we see those behaviors that are associated with some of the children that we end up working with, or even the adult. So that becomes incredibly important. So again, at the bottom of that baseline, and here's how the brain of somebody with complex trauma has been impacted, is again, at that very core of the brainstem at the bottom, which is responsible for all of like instinctual parts of your brain, automatic, it is impacted by the environment. So if it chronically sees threats in its environment, at home, in the community, then it becomes a heightened sense of arousal. So their heart rate increases, their blood pressure increases, all of the necessary things for somebody's fear response system, which is adaptive, but not if it's ongoing. As the limbic system continues to develop, then that's where the fear response system is. That's where that amygdala is, that releases the adrenaline, cortisol, right? The hypothalamic pituitary adrenal axis that Dr. Nadine Burke-Harris talks a lot about in that TED Talk, that it releases all of these stress hormones because its job is to keep you alive. If a child is in a constant state of threat, then what happens is that that brain becomes sensitized, and their brain in the limbic system is now predominantly assessing for constant fear. It's predominantly assessing for threats. So the importance of that is that amygdala, figuratively, not literally, becomes larger and larger, assessing constantly whether or not there is safety. So then why can't children then learn? Because it's an irrelevant skill in survival. The only thing that becomes important when a child's brain is in survival mode is what do I need to do in order to survive? So if a person has experienced trauma during the time when their limbic system was developing, at childhood, they'll be triggered to function primarily from this region when they're dysregulated. So when they hear something, if they feel that they've been challenged, if other kids are arguing or fighting, if a teacher raises their voice, and when a person is functioning from their limbic system, then they appear to be emotionally reactive, relationally aggressive, and may appear to mistake social cues, where they're taking things a lot more personal. We see this all the time in a treatment facility. You're likely seeing it with the ones that you are working with. This poses them as risks for future substance use as well. All the way at the top of the brain is the cortex, which is the rational part of the brain, which is the calm part of the brain, which is the part that helps them to weigh the pros and the cons, to think through their choices. So when you work with somebody that's had complex trauma and they're able to say, I know I shouldn't have done that, it's because in that moment, while they're identifying safety inside of your office, they're in their cortex, and their cortex is more rational. What's happening is that when they're engaging in the behaviors, they're limbic system dominant. They're showing you that they are in survival mode. So treatment becomes about how to help them recognize when they're in that survival mode so that you can help them to reassess and get regulated. So again, I'm not going to kind of highlight over that, the hierarchy of brain development. Again, it's sequential and it's hierarchical in fashion. Again, it develops from the bottom up. It does not start at the top. This is why when we see behaviors associated in regular development, regular quote unquote, then you'll see, adolescents are a lot more emotionally dominant. They're risk-taking, they're reactive, they're impulsive. They think everybody's talking about them. They're literally showing you that they're in their limbic system. When it starts to exceed, but they have the ability to utilize the cortex, it's just not easily accessible. For somebody that's had trauma, who's living in the limbic system, they are constantly assessing for fear, for safety. They're constantly assessing, is this environment safe for me? Is there a threat? Because everything is easier triggered, and it's harder for them to get back to baseline, that when we're looking at that, the bigger the threat, the less rational they are. So if there's minimal triggers, then they react, but then they can get themselves to start coping skills. I shouldn't have done that. I'm going to do X, Y, and Z. But when the trigger is so profound, and this is where we see this with complex trauma, they're so far down in their limbic system that they're not able to be rational to think about the consequences, so they're very reactive. Throwing a desk, in hindsight, probably shouldn't have done that. In the moment, that's the only thing that they thought to keep themselves alive. Substance use sits in that same part of the brain. And what Dr. Nadine Burke-Harris talks about is some of the structures that are impacted by childhood trauma. And one of them, which is also in that limbic system, is the nucleus accumbens, which is responsible for the pleasure reward center. Essentially, as a result of some of the trauma, you have what we could consider a dopamine deficiency. Dopamine being the neurotransmitter that we all want to feel happy, to feel good, that you would get with food and sex. But when there's been trauma, they don't produce the same amount of dopamine. So when you are then using substances, you need more of it to get that final, finally, I feel good. I feel euphoric. I feel happy. Those are the vulnerabilities in regards to how somebody develops a substance use. It's a lot of information. I apologize. The limbic system. So again, when trauma happens, you go limbic. So essentially, what happens is that we immediately recognize that the only way we can get them to help them is for children is how to help them understanding their brain and the consequences. So fear, again, when this trauma occurs, is our most primal emotion. and with good evolutionary reason, right? We are trying to survive. Fear literally arises from the core of the brain, affecting all brain areas and their function. The brain evolved from the inside out, as I had said, from the bottom to the top. The midbrain and the limbic system develop after the brainstem. And this is where they sit predominantly until later adults. So when people say the brain's not fully developed until their late 20s, mid to late 20s, it's the limbic system is where they're still kind of hovering as a dominant. The cortex is the last thing to develop. The fact that the brain develops sequentially and also so rapidly in the first years of life explains why extremely young children are at such a high risk of having long-lasting effects of trauma, because their brains are still developing. So this is where there's the difference between something that happens to you when you are under the age of 24 versus when you're older. And there are critical periods during brain development that when this occurs during those critical periods, it has longer lasting effects on the brain. So that plasticity that allows young brains to learn quickly and learn language also makes them more susceptible to these experiences. The vulnerability to the lasting effects of trauma depends on when it occurs. And as a result, different symptoms may result from trauma experienced at different times. So again, when we're looking at how this is impacting not just the amygdala, the hippocampus that's going to recall and associate memories with it. If a toddler with no language is to describe the painful abuse that she's experienced, that would be a complete aversive to being touched, a wide ranging of problems with intimacy, relationships, and pervasive anxiety. But they can't verbalize it because they didn't have language yet. A 10-year-old that might have had the same exact experience of abuse could develop specific event-related fears to work deliberately to avoid those particular cues, right? So they avoid certain situations. They don't, there's higher levels of anxiety. It might be specific to the gender of the person that was the perpetrator. But the anxiety will kind of come and go with the exposure of those reminders. That's where we see the inconsistency. So when we're looking at any age, when people are faced with a frightening situation, their brains begin to shut down their highest cortical regions first, and we lose the capacity to plan and feel. So all of that becomes important in our understanding that when you see somebody displaying some of the behaviors, so this is kind of just a different way. This is the cortex. This is the part that gets shut down. So I'm going to skip that because we're getting closer to when this would end. That when we start to recognize that with any prolonged fear, there can be chronic or near permanent changes to the brain. This is how that whole hypothalamic pituitary adrenal axis, and again, when you watch Dr. Nadine Burke-Harris, she'll be talking about it, is the amygdala is going to identify the stressors. If you've had significant experiences in your childhood, your brain is going to be impacted differently. The last part of the brain that is going to be utilized is that prefrontal cortex. The hippocampus in that same limbic system is assessing for all the cues. That's why certain people get triggered by certain things, because right next to that smoke detector, that amygdala, is the hippocampus saying, that scent reminds me of when this happened to you. That sound reminds me of when this happened to me. That person looks similar to the person that did this to me. Those are the context cues. There's 5 senses, so the brain is constantly assessing. And the bigger, figuratively, not literally, the bigger the amygdala, the greater the sensory cues. That hippocampus is storing everything because its job is to keep you safe. So when you see a child that is engaging in behaviors that are uncharacteristic to the situation, they are likely demonstrating the traumatic responses that they have learned to survive. Fight, flight, freeze. Freeze is the dissociative quality. So that is what they learn from a young age. They will continue as they get to be an adult. So when somebody is responsive, so that, again, the biology and physiology of survival, when children or an adult feel threatened, it fast tracks the experience to the limbic system, which is much quicker than the cortex. So the limbic system is text messaging and the cortex is mail. It responds so much quicker that they become much more reactive. And again, as I had mentioned earlier, if a person has experienced trauma during the time when the limbic system was still developing, they're more reactive, they're more relationally aggressive, they are, impulsive. So punitive measures don't oftentimes work. Taming the brain becomes more effective. So again, when we talked about the brain development, and I've kind of already highlighted some of these things, it's an easier way as we kind of go through this, is that what we're looking at is, again, the developmental plasticity. That's what I was just referring to, is that depending on when the trauma occurred is going to determine how the brain was impacted. The order of the development, so from the bottom up, from the inside out. So some people, again, depending on your age, I know people do like the thumb example of like, the amygdala is inside and your hand is the cortex. So however you do it, again, I predominantly work with adults. So I really just describe it, and I actually describe it in that triangle from the bottom up. Because what I want you to know is, where are you? Because if you are in the limbic system, I need you to identify, and that's what we'll talk about with treatment. I need you to identify the treatment that's going to help you in the limbic system to get you to the cortex so that you can engage in some of your coping skills, so you can think through the consequences, so you can, weigh your choices. And that's where, again, as I had just mentioned, the timing of the development, that these different developmental domains occur. All of these things are occurring within the brain, the biological, the psychosocial, the emotional, the cognitive. All of these parts are interwoven to the experience of a child as they develop through life that can be impacted by trauma. So we see this a lot in regards to the legal system. For those that are in the juvenile justice system, it becomes an important piece to recognize what had happened, what did you learn to do to survive, because whatever their behaviors are, I learned to fight, I learned to do this, I learned to use substances. So I don't want to discredit that you learned to survive, but can we learn different skills? But if we keep in mind that whole idea of the limbic, they lose it or use it, we have to recognize your brain has really geared itself towards the autonomic response of like, these are your skills. So we're going to slowly start increasing some of these others. So I do see a question, can someone be limbic system dominant without trauma? So it doesn't have to be trauma, it can be stress. Personalities also, so there's some babies that inherently are born more or less reactive, right? There's like they call it like nervous system enhancers and diffusers. So there's some people that are a little bit more sensitive to the experience, but keep in mind the stressors. So yes, somebody can feel more limbic system dominant. It's just, does it shut down the cortex? And again, it doesn't have to be a traumatic event. So can there have been things that happened to you that were stressful in and of themselves that just kept increasing the levels of cortisol and adrenaline, right? So sometimes people would argue like type A personalities tend to have more adrenaline and cortisol in their body. They're a little bit more reactive. So it's not a safety issue that they're not assessing. It's not the amygdala has hijacked the brain to assess for safety, but it's that there's just this chronic sense of, different neuro or physiological experiences and neurochemistry. So I'm not going to highlight this again, the development of plasticity, because I just talked about that. That's the ages of, when you have a lot more plasticity in regards to brain. So you're seeing that in that curve of 25 to 26 is when your brain is really susceptible to a lot of changes. And that's where the brain's ability to change in response to experiences, pretty significant when you're little. And then it goes down as you get older. And the amount of effort to change goes adversely related. So why do some people have more detailed memories while others have no memories of childhood trauma? So again, without getting into a lot of detail, so I'm just skipping through because I'm going to highlight some of the interventions. What can happen? So again, that hippocampus is it's a pretty important role in regards to trauma. So it is holding on to cues, but what can happen for some individuals is this idea of like the disassociation, or it gets flooded with so many stress hormones that it overwhelms that part of the brain that retains memory. So some people, again, that disassociation occurs from a different level of the brain. So not out of the, again, just at a different level of the brain that allows for you to learn freeze as a response system because fight or flight didn't work. But it can dramatically, because it also, so long-term trauma can impact the hippocampus's development. So it starts to prune away memories. So significant events, again, depending on the chronicness of it. So like when one person has like a chronic event, so this is why, you know, people remember 9/11 because it surged, you know, these like stress hormones into your brain pretty quickly. It's almost photographic. When it can become chronic in nature, that you start to learn disassociation, those childhood memories can fade away because it's a part of your brain's adaptation to trying to help you to survive. So in a very, not as much of a technical way, because I think that's, again, that's a whole, almost a whole nother lecture. That's some of what is related to it. It is still the development of the brain. It's still the way that the brain is kind of helping you to figure out how to survive these things and how do I disassociate from these people, these memories, because it was flooded consistently with these certain transmitters that helped to minimize the experiences of remembering certain things, different than when you had like an event that becomes almost photographic. So sorry, I can't get into too much of the detail, but again, there's a lot of great research on that. So if you are interested in learning about like the childhood memories and the dissociative qualities or not being able to remember, there's some great books out there that have that. So then what are evidence-based treatments? Again, we are right at almost the 1150, so I'm going to kind of just wrap up. These are strongly recommended. So these are PTSD. These are evidence-based programs, so CBT, cognitive, so yes, cognitive processing, cognitive therapy, prolonged exposure. So these are evidence-based practices that have been associated for PTSD. I'm going to talk a little bit about treatment components for complex trauma. So can you repeat what I said about the connection between trauma changing the brain and why a person is more likely to use the substances? Yes. So, well, not just the connections, but again, what we're looking at in regards to trauma are some 3 areas of the brain that are pretty substantial in having been impacted. The amygdala, the nucleus accumbens, the prefrontal cortex. So the fear response system is significantly impacted if somebody's experienced trauma. The nucleus accumbens, which is the part of the pleasure reward center, has been, for lack of a better term, depleted. And then the prefrontal cortex, the part of your brain that allows you to A, feel safe, but most importantly, helps you to weigh your choices, weigh your consequences, delayed gratification. When trauma occurs, it increases the experiences of somebody feeling hypervigilant, and it decreases the person's experience of being able to feel content, happy with that pleasure reward center. So when somebody starts to use substances, they oftentimes require more so that they can get that dopamine release. And the fear base of it is that they are chronically sitting in that autonomic nervous system arousal. So they're looking for a sense of peace. And the substance, again, in that limbic system, people decide what works, not what's good or bad, right or wrong, but what's going to make me feel better. In the survival part of the brain, it's what is going to help me in that moment. When somebody starts to use a substance in just an attempt to feel better, it worked. And so it is more likely the hippocampus is going to keep that memory of saying, this is what worked when I had flashbacks, when I have, you know, high levels of anxiety, when I'm feeling depressed, when I'm feeling unlovable, when I feel like nobody's ever going to be there for me. When I use that substance, it filled the part of my brain that I haven't had filled, and I'm going to keep doing it. That's the increased vulnerability. So when we're talking about, and this will be my last slide, treatment components for complex trauma, relationship building and support. Again, you are healing the brain. When you are engaging in relationship building, you are going after the cortex. You are attempting to heal the brain in just those relationships. That therapeutic relationship is essential. Safety intervention, so again, grounding skills, how to recognize where I am. I will say this was a good friend of mine that had said this. When you work in the field of substance use, you are looking at things moving quickly, right? You either have positive or negative. You're either, using or you're not using. When you work in the field of trauma, it's slow. It is slow moving because the longer somebody has experienced trauma, the slower the work is. So be patient with it. So safety interventions. How do you understand what feels and acts safe? What does that mean in regards to your relationships, in regards to how do they assess it? Education about how the brain has been impacted is incredibly important. If you are working with children, educating their families so that they can also recognize when they are being limbic system dominant and reacting in their limbic system as opposed to their cortex, because two limbic system environments can't create safety. Providing distress tolerance and affect regulation skills. So again, breathing and body movement and, ways to control the limbic system and ways to recognize it. Cognitive processing can then be a part of it, is restructuring the way that they understand the process when somebody feels guilty that they didn't fight back when they were little, right? So there's the cognitive processing, the trigger identification and intervention, and then the small titrated exposures. So I'm really anxious when I do this that you start to expose them in titrated. Group therapy can do that, opportunities for somebody to engage in some of those skills. So I apologize that was a little bit quicker towards the end. If you have any other questions, please do not hesitate to reach out and let me know. I'm hoping that at the end of this, what you were able to gather is that there are real reasons why somebody engages in the behaviors that they do, and that the more compassion we have for them and the way that we respond to them can help them with the healing process, because they are engaging in skills they think is helping them to stay alive. And it is our job to help them to recognize there's more than one way. But they can't trust that if they feel consistently stigmatized. So I appreciate you attending today. I am grateful for your attendance. Please don't hesitate if you have any questions.
Okay, Trish, thank you so much. We do have a couple of questions. Would you add accelerated resolution therapy to either recommended treatments?
Would I add what?
Accelerated resolution therapy. He has it, ART. It's called ART.
I have to be honest, I'm not sure. I'm not familiar with that.
Okay.
Accelerated, is that the brain imaging?
Maybe that person can respond in the chat.
Yeah, it might be the brain imaging, like the spot, like the brain mapping.
Okay. And it was mentioned that there is a disproportionate number of children diagnosed with ODD when in reality they have PTSD. In your opinion, what is the reason? They were having problems with their audio, so they weren't sure if they missed that piece.
I mean, I think that the symptoms are going to look relatively the same. So if you've got a child that's experienced trauma, they are going to be more reactive. They're going to be more impulsive. They are going to have relational aggression. And so it's the interpretation, that lens that I was saying, a strength-based lens is that this is what that child has learned to survive. When we diagnose, and I will say it does seem to be disproportionately recognized, is in underserved communities, we tend to label them a little bit more with ODD as opposed to recognizing that their traumatic experiences are increasing the symptomatology, because on a piece of paper it looks the same. But trauma we have to treat, and ODD we get to punish.
Okay, so we had an explanation on the ART therapy. It's a newer EPB. It's a trauma therapy, not brain mapping. And then someone mentioned it's an eye movement treatment.
Oh, okay. I'll have to look it up. Yeah.
Okay.
I'm less familiar with that.
And then in assessing adults, is it more appropriate to diagnose complex trauma rather than reactive attachment disorder due to the evidence of childhood trauma?
So that's a whole nother thing, is that what we will find is that most of those that have had a reactive attachment disorder are going to have had early childhood trauma. I will say as a disclaimer, this is my personal experiences, is When we incorrectly, to me, it's the same thing. When we diagnose a child with ODD, we're basically sending them down a pipeline that says, we'll see you in conduct disorder and down in prison. When we diagnose somebody with a reactive attachment disorder too soon and not review and start to explore trauma, symptoms, and treatment, reactive attachment is basically saying the harder you try to love somebody, the more they're going to become reactive. I have worked with many of those that have had that diagnosis that really had profound trauma, that we were able to heal the systems together, because if we don't do that appropriately, then what we're telling the family is that you can keep trying to love them, but every time you love them, they're going to hurt you. And it can inadvertently perpetuate the abuse. So I would be very careful with diagnosing somebody with reactive attachment before really starting to implement some of those trauma therapies. And you can have appropriate conversations, but that's a hesitancy that I have because I've seen it. I've seen families be like, well, you know what? I was told that they have reactive attachment. There's nothing else that we can do for them. If we love them, they're going to act out worse. When we take a trauma-informed approach, we're able to see, can we heal this brain together? Can we start to move through these things together? Because this is an adoptive family. If you have reactive attachment, oftentimes this is as a result of adoption.
Thank you, Trish. And I don't think we have any other questions that I've noticed. I did see a comment that the ART is an offshoot of EMDR.
EMDR. Okay.
So, Trish, thanks again so much for presenting today. We always enjoy having you. And I have put Trish's information up on the screen so that if you need to contact her, there's her email address. And if you can just hold on, we're going to go through some housekeeping items. When we conclude today's webinar, your browser is going to take you to an evaluation on FADA's new website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You'll be prompted to register or sign in to complete the evaluation. So you can register as a visitor for CEs to be reported to CE broker for Florida licensed healthcare practitioners. You must provide an accurate Florida Department of Health license prefix and number for the first time you register. And after you register and sign in, you will be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA system, and this helps connect your attendance and your profile. You'll get a second opportunity to complete the evaluation through a follow-up email later today in about 30 minutes. The sender will be Messenger at WebEx, and the evaluation will close at midnight on Tuesday, October the 13th. One thing I do want to mention is that it does take up to 30 days to post your credits. So once you complete the evaluation and the evaluation closes, it takes up to 30 days after that. And we do try our best to have the presentation and recording posted within 30 days. Usually it's sooner, so I know a few of you have asked about that. One last thing is we do not email statements of credit. Instead, after we verify your attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile, so it's your responsibility to go into your profile and print that information. So again, you have to create a profile and your statement of credit will be up within 30 days. We'd like to thank you for participating in today's webinar. We'd also like to recognize and thank especially the Florida Department of Children and Families Office of Substance Abuse and Mental Health for funding today's education. And have a great rest of your day. Please hold for the evaluation. And thanks again, Trish.
Thank you.
Have a good day.